orthobiologics or modalities that we're using in this field. So I'll just get right in right now, okay? So here's kind of the list of everything we'll be talking about, really the ones with the stars, what I'm gonna concentrate on today, and then, you know, myself, I'm gonna be talking about adipose later. Jeff's gonna be talking about PRP bone marrow. Dr. Stafford's gonna be talking about PRP, and then Dr. Garg's gonna be speaking on shockwave and EMTT. So this is just, again, an intro, but we'll get into more later on in the day as well. And in the past, we've kind of gone through every single study and kind of dissected each study. I'm gonna list all the studies, but we really want to talk more about, you know, how you guys can implement it, what are the right things to do. So you'll have all the references, but we're not going to dissect every single study today, okay? All right, so we'll start with PRP. I'm sure a lot of you know what that is, but platelet-rich plasma, where we concentrate the platelets and the growth factors from a patient's own blood, so autologous, concentrate them to a higher concentration, and then, you know, re-inject back in to the patient. You know, we'll be doing some ultrasound also today, and that is definitely the preferred method, or some kind of guidance, either fluoro or ultrasound, making sure that's getting right in the location that we need it. So yeah, so obviously it's a venous blood draw. You know, there's single spin, there's double spin. I prefer the double spin technique. There's kits, there's manual processing, but typically most people are using kits now, and with the FDA, unless you have a CLIA certified lab, there's, you know, it's really technically, you need to use an FDA approved kit in the US here. We do a lot of measuring and follow-up, so, you know, I like to check in with the patients or the service that I use that kind of tracks all my patients, you know, at 1 month, 3 months, 6, a year, and 2 years, and see how they are doing along, and then we can bring that back and give our other patients guidance. If we do this procedure, these are the likely outcomes or percentage that you will get better. So these are some of the landmark studies. Again, we'll go into more of those later, but these are the ones that really started to define the positive outcomes that are associated with PRP. Again, these are some great studies to have to reference back to and to look at as far as how it's progressed, and then, you know, a lot of systemic reviews that kind of pool everything together and show that this is working very well, it's safe, and more recently there's been studies showing where, not that it's not going to work, but that you need a certain level of platelets, either 5 billion or 10 billion, to have a good response. So that's what in the last couple of years, there's been a few more of those studies that have come out that have really showed where you need a specific dose, a dose response. Just like a blood pressure medication, you give someone 5 milligrams of lisinopril, that doesn't lower everyone's blood pressure. Sometimes you need 10, sometimes you need 20. So there really is a dose response with PRP that we have been finding out. And then this is one that just came out last year that showed the specific doses of PRP and if they were good outcomes in the study or not. And a lot of the trials that show no difference or that it's not effective were not using a very concentrated PRP, and that, again, is essential where you need to hit that certain threshold to get the response from the patient the pathology. So again, this is just kind of basics of the PRP. You know, there's a lot of stuff in blood. You know, over half of it is plasma, the white blood cells, red blood cells, and then, you know, the platelets. So that is what we're aiming for. There are different types of PRP. You know, just the basic would be leukocyte rich, leukocyte poor. But I would say the number one thing you want to concentrate on is the number of platelets that you would be injecting, because from, you know, all the studies, that has consistently showed the most positive results if you get above that threshold of platelets. So there's multiple growth factors that are released, and that is why it has been working so well, that can stimulate healing and then stimulate other cells to come to the area to help out. So these are the main ones that we are seeing with the platelets, and that's really their function. You know, they stop bleeding, and, you know, you get a cut. They're the ones that are stopping the bleeding, but really what we're using it for is to get all these growth factors to stimulate the healing. Again, this is a fancy slide that kind of shows all of the mechanism of tissue repair. So we're not going to have a test on this later, but if you're interested in knowing the exact science of it, you know, this is a very good slide from a paper in 2013. So we want to look at angiogenesis, you know, increasing the blood flow into the area, increasing the growth factors in the area. So the VEGF and PDGF are very essential for this healing process. But then, you know, like insulin-like growth factor is more of a systemic thing. So we're really signaling wherever we're injecting for the whole body to heal that area. So we're kind of tricking the system, usually in an area that is not getting the best blood flow. So that's a tendon, that's a joint, where muscle, skin, you get an injury there, you're going to pretty much heal on your own in most cases. But a lot of the pathology we're seeing is ligaments, tendons, and joints, which are encapsulated, so you're not getting the best blood flow in those areas. So that's why we want that angiogenesis to be coming in and doing the healing. So again, these are multiple trophic growth factors that, again, are stimulating the healing in that area, and, you know, kind of supercharging the healing process, getting the body to put its energy, put its effort to the point of where we are injecting the PRP. All right, so typically, and this is pretty much the same with an injury too, you sprain your ankle, whatnot, that's kind of what I tell patients when I inject a PRP is, like, think of it like you just got a new injury, but so the body's going to kind of concentrate on that area. So the first phase is the inflammatory phase, so that's why you can get a little flare up at the beginning, and then, you know, once that kicks in, then we get the proliferative phase, so we're getting collagen, everything coming in, and then as well as the fibroblasts, and then, you know, after about 10 days, then the remodeling phase. So there's different types of collagen, and so it's trying to get as much material there initially. So we got the inflammation, we got all those growth factors that I just talked about. Then we're putting down collagen, and then we're modeling it, you know, lining up everything. If it's all off center, then that last remodeling phase is lining everything up and getting it to a good tendon, a good ligament, whatnot. All right, and then just a little bit about the rehab principles, and this goes hand in hand, you know, with this diagram. Is with that inflammatory phase, we don't want to start rehab right then. We kind of want to let it rest, let it sink in. So typically the first couple weeks, We want to get, you know, range of motion. Again, I do not like anti-inflammatories in the first 2 weeks. So usually, if they need anything, we're using Tylenol. But you can start a little bit of range of motion and more isometrics. All this was based off a paper by Dr. Mottner at Emory, and it's been working out great, but there's not randomized control trials that show, oh, you have to do this at 2 weeks, you have to do this at 4 weeks. But this is what I've been using for, you know, since 2016 probably, and it has worked out really well. So typically, if we're going to get them into physical therapy, usually at a week, they can get in, do some manual stuff, do some modalities, but as far as strengthening, like if it's a tendon, usually starting at about 2 weeks. And then, you know, as far as actually really pushing it, I tell most patients, you know, it's going to be about 6 weeks before we think about going back to, if they're an athlete or whatever sport they are in, or just, you know, going back to really pushing it. It's going to be about 6 weeks and beyond that remodeling has occurred. It hasn't finished, but at least everything is lined up and where it should be. So 6 weeks and beyond is when we can start light plyometrics, go back to the training activities, and then kind of see how that goes, because it's going to keep, in theory, improving, you know, for and remodeling for up to 6 months after we do an injection. All right, so that was a very brief introduction to PRP, but like I said, Dr. Stafford will touch a lot more on that. So the next biologic I want to talk about is A2M, so that's alpha-2 macroglobulin. So it is a big protein that floats around the body, that is not present in our spine or any of our joints, but it's basically a big protein that gobbles up inflammation and kind of decreases inflammation around the body. So Dr. Scuderi was kind of the initial guy that researched this. He's actually has an office kind of right around here in Jupiter, but he was the first one to kind of try to isolate that and deliver it to a knee joint or to the spine to try to calm that down, decrease the inflammation there. So there are multiple kits that can isolate that or concentrate the A2M. Most of them are filters that are cutting off at certain kilodaltons, so we're getting everything under or over a certain size, and this is a very big molecule, so kind of the higher the cutoff as far as the different filters go, the higher concentration of A2M we see. So there have been studies that show it slows down the progression of osteoarthritis. I've done a lot of them right after an ACL or any kind of injury to the knee that usually gets post-traumatic arthritis. So that's what I use it for a lot. But if you tried other modalities that are not working, you know, this is kind of like a natural cortisone or anti-inflammatory that can really, you know, autologously calm down a joint and in theory stop or slow down, slow down the progression of developing osteoarthritis. So the most studied application is knee osteoarthritis. Obviously that's the #1 joint that gets arthritis. So again, if it's inflamed, any kind of inflammatory condition, doesn't have to strictly be osteoarthritis, but that is what we are using it for the most. So these are 3 recent studies that kind of compare A2M to PRP and corticosteroids. and obviously no negative side effects. It's all your own material compared to, hopefully we all know here, some of the damage and the negative side effects of doing cortisone, especially multiple times in a joint. We know that's gonna degrade the joint, break down the cartilage. So this is a great alternative, to doing a cortisone shot. So this is kind of similar to PRP. We're getting a big sample of blood, separating the plasma there, and that's where most of or almost all the A2M hangs out. And then once we have that plasma, then we're filtering it and trying to concentrate that A2M as much as possible. So yes, the ideal candidate is mild to moderate osteoarthritis, and you're going bone on bone. It's still reasonable, but most of the studies show pretty good efficacy with mild to moderate arthritis. And then, obviously this is...
Do you inject PRP with your A2M?
I do not. So no, I can do it. What I like a lot, if we really want to get, in theory, the best possible outcome would be doing an A2M a week before, getting everything calmed down, and then hitting it with a PRP or a bone marrow or an adipose, because the joint gets angry, and it would be much better in theory to have a calm down joint than to have it really irritated while you're doing a bone marrow, a PRP, or an adipose. So yeah, thank you for mentioning that. So that is also a great indication. And I know in sports medicine, there's a bunch of departments around the country that are basically swapping out the cortisone shots on their athletes for this. So number one, it's working, but number two, guys that played football or basketball in the 70s, 80s, and 90s, they all got cortisone shots all the time, and they're all probably have knee replacements now. So this is a great alternative to that cortisone that I've said multiple times. So yeah, the main outcomes we're expecting is decreased pain, improved mobility, and then in all the studies there's minimal adverse events because obviously it's coming from your own body, it's already in your body, and we're just concentrating it and injecting it in. All right, so I just put this slide in here, but exosomes is a huge word, a huge buzzword around the country. I work down in Miami as well as up in Connecticut, but every Instagram or every ad is really pushing the exosomes, and currently it is illegal, or not illegal, but the FDA does not have the approval since 2019 to do any kind of exosomes coming from birth product or allogenic, and so that is really the only two systems right now that can concentrate exosomes, again, autologously, is the SuperShot PRP. We're going to have a presentation on that. Then there's a company that has a product called PPX, where you take a sample of blood, you ship it to their lab, they ultracentrifuge it and get your autologous exosomes back, and then ship it back to the doctor's office. Seems like a pretty crazy process. I have not tried that, but I honestly do a lot of SuperShot with my PRP injections, and personally I find that when you have the exosomes added back into the PRP, that if you're going to get a flare-up, it's a lot less when you're doing it with the SuperShot, and quicker outcomes than I'm used to with PRP alone, or same thing with MSCs and PRP added with the SuperShot. Seems like it accelerates the process. I have a lot of colleagues in derm, people doing hair regrowth or sexual health as well, and they're seeing superior outcomes and quicker outcomes with the addition of the autologous exosomes. All right, again, I'm gonna give a lecture later on adipose, but I just wanted you guys to have all the studies that you know are kind of the essentials, basically the first one, some of the major ones. Most of them are case reports and theory ones, but now we're starting to get randomized control ones in the last 5-10 years. So it's really progressed as far as the amount of research that has been done. Typically, you think orthopedics, you think bone marrow, and that, I'd still say that is dominant as far as stem cell. We're not gonna call it really stem cell to our patient, but as far as MSCs, which are the mesenchymal stem cells, or we call them medicinal signaling cells, that the bone marrow has been dominant in this country. They were doing a lot more adipose in Europe, I'd say before it, but now it's definitely gaining some traction here, and now there's different times where I prefer using adipose, different times where I prefer using bone marrow, and we'll definitely get into that at the next lecture. So same thing with the bone marrow. These are a bunch of the studies. That's the thing, is they were studying that back in the 60s, 70s, 80s. That was when everything kind of first started with bone marrow, where you can see with the adipose, the first major study was right at around 2000. So we're playing a little catch up with the adipose, but making great strides recently. All right, and then another thing we're really going to concentrate on today with Dr. Garg is the shock wave. So I won't, rain on your parade, let you go, but
you're fine. The more times you hear it, the better it'll be. So don't
Yes.
worry about it.
all right. So basically, this is not truly an orthobiologic. It's not a biologic. It's a modality that stimulates the biology in your body. But it basically delivers acoustic therapy, acoustic shock waves to the tissue, to the joint, promotes tissue healing, neovascularization, and regeneration. So it's kind of in the same realm as everything else we're talking about. I use it, all the time. That's actually my go-to before deciding on a PRP or a more advanced technique. I always use that, see how it's responding as far as that goes. And I actually use it as, I have an ultrasound all the time, but I use that as a diagnostic tool. And that we have a few devices for you guys to play with, but say someone's shoulder's hurt, I can put the shock wave on them, kind of move it around, and they'll tell me that's the spot right there. And if there's no pathology, it's really not gonna, you're not gonna have a reaction, it's not gonna hurt. So I really like it as a backup or even the first line as far as diagnosing exactly where the issue is with the patients. So the primary indications, plantar fasciitis, lateral epicondylitis, and then calcific tendonitis. So the technology in the shockwave actually started from lithotripsy. So when people have kidney stones, it's a lot more powerful than the shock wave we use, but that's where the technology comes from, where sound waves, pressure waves are breaking up that material. So that's why, calcific rotator tendonitis is, one of the huge indications for that. But you can use it on the Achilles, and then also for fractures, that really speeds up the healing. Yeah, it's kind of side note, but my aunt, she's 82, she fell, broke three of her vertebrae, and she was in a brace. 6 months later, she saw no healing whatsoever on the CT. She's in Tucson, Arizona, where I grew up. I found one person that had a focus and a radial shockwave in Tucson. Sent her to him. She had about 10 treatments. Went back to see her neurosurgeon that was planning on doing surgery. He's like, I've never seen this before. You're healed now. After 6 months, it's not like automatically you're just going to get some healing. But that is a huge part of the shock wave. It really promotes that healing of of the bones, and, you know, of all tissues that we treat, and non-invasive as far as that goes. So here's a bunch of studies. I'm sure Dr. Gard will have more, but just wanted you guys to have all those. All right.
I have 0 studies in my case. We're gonna go over like real world applications.
All right. So that's why I did this,
This
to
is
make
why
up
Tad's
for.
awesome at this. Yeah,
Done this a couple
there you go.
All right, and then the last thing we'll talk about, and again, we're gonna have a presentation later on, is the laser. So again, that's not a biologic, but it's stimulating a lot of the same mechanisms that we're using with PRP, with stem cells as far as that goes. So that's becoming a lot more popular. I'm using it a lot in my clinics, and if any of you are doing PRP, there are times where, you know, you're doing a tennis elbow and the patient gets a pretty big flare-up right afterwards. I throw the laser on right afterwards, and it's calmed down within a couple minutes, and it's truly stimulating the injectate, whether, you know, it's PRP or bone marrow adipose. It's, you know, photo biomodulation, so it's really helping activate more of those platelets, and calming down where that injection was. So we have a lot of options now. You know, it started, we just had PRP, then we had bone marrow, then adipose, and now we have a lot more modalities. None of them have, you know, been proven harmful to the patient. Obviously, if you missed a joint or go somewhere, that's why ultrasound or fluoro guidance is very key. But again, they're all autologous, they're all coming from the patient's own body, so it's really hard to react. And, you know, another side note, they use a lot of these for wound healing. So that's the thing, is there's really been very, very few infections caused by any of these, and that's because they're basically antimicrobial, so that's why they're very safe. There's a lot of different factors influencing the choice of treatment, severity of the disease, and also the severity of symptoms. Someone's bone on bone, but they don't have any pain, doesn't mean you have to jump to, you know, an adipose or a bone marrow. You know, you could probably get away with a PRP even for very severe arthritis. So it really matters, you know, how their symptoms are, how severe the disease are, and then we also know that these are not covered by insurance. So there is that cost issue. So typically, a consultation with my patient, I'm giving them options. I'm not saying you have to do this or you have to do this. I'm saying this will help you, this could last this long, this will help you, this could last this long, you know, depending on the research. So it's nice to give options as far as the patient that's paying out of pocket. So this is something from the clinic up in Connecticut that is just, you know, a very general thing, but, you know, the more severe the disease, kind of the higher level of treatment that we want to give, but it also is a higher cost as far as that goes. All right. Well, that's the first lecture. That's a nice little intro. So, you know,
Well done. Very well done.